Hello, it's Dr. Butzen. I'm an orthopedic surgeon. I live and work in Durango, Colorado. Today we're talking about the rotator cuff. Now, the rotator cuff is a part of the body that is commonly injured, especially as we get older, or it can be injured with an acute trauma, such as a fall or a ski crash, mountain bike crash, that sort of thing. And so it's important to understand the anatomy of the shoulder and how the rotator cuff plays a role. The rotator cuff is probably the most commonly injured part of the shoulder, and it's responsible for a lot of the work that I do. We do have some solutions that are non-surgical that are definitely worth trying. And so let's go through this so you understand what is going on in there, what tends to go wrong with these types of injuries, and what we can do about that. So today we're going to start about talking about the anatomy of the shoulder as well as the physiology. And the physiology just is, how does the anatomy move? What are the biomechanics? How does that all work? Then we'll talk about the rotator cuff, which is the weakest link of the shoulder. There's a lot of other muscles in the area that support the rotator cuff. And so when you do have an injury to the rotator cuff, those supporting muscles are overworked and cause more pain. Then, of course, there's the process of tearing of the rotator cuff. We're going to go through conservative treatment. I will briefly go over treatments that I provide, both surgical and non-surgical, that can be helpful for this. So as we go through the anatomy, it's helpful to start with the skeleton. The shoulder has the greatest range of motion of any joint in the body. And so essentially, because of such great range of motion, it puts more stress on the adjacent structures. That's where the rotator cuff tears come from. Also, it's very common to dislocate a shoulder because there's a trade-off in stability for that range of motion. The rotator cuff, as a result of this trade-off with stability, the rotator cuff is very commonly worn out as we get older, and that's how a lot of these rotator cuff tears do happen. The important thing here with the anatomy is when we start looking at this, this is the chest wall and of course the shoulder blade, but the shoulder blade really is to the back. So as we're looking at a lot of these structures, the drawings show it as if we're looking straight at the shoulder blade, but the shoulder blade is actually tilted about 45 degrees to the back. As we look at the more about the bony anatomy, what we consider the shoulder joint is this joint right here. That's called the glenohumeral joint. That's the ball and socket joint of the shoulder. There's also what we will call the scapulothoracic joint, where the shoulder blade attaches to the chest wall. And so when we get motion through the shoulder, we actually get motion through both of those joints. When the whole shoulder blade moves, the clavicle is the collarbone, and that gives us a little bit of motion there. There's a little joint here called the AC joint, or acromioclavicular joint, and this is the SC joint, the sternoclavicular joint. And so those have little joints that move as we shrug the shoulder, retract it to get a little more motion out of the shoulder joint. Because of this, we get such great range of motion as we get contribution from the ball and socket joint and from the shoulder blade moving on the chest wall. There's also deep inside here, there's the socket. We don't have a great drawing of that today, but there's the socket, which has a concavity, and then there's a thing called the labrum, which is a lip-like structure. So these are the deepest layers. There's a lot of soft tissues that support the shoulder as well, in addition to muscles. And the next layer is this sort of middle layer of the shoulder. This is the rotator cuff. These are the muscles that support the shoulder. The main thing that they're going to do is keep that ball and socket joint lined up. Now, in order to do that, because there's so much forces from everything else, which we'll go through in just a minute, the rotator cuff is always under a lot of stress. The supraspinatus is the muscle that's over the top. That's the muscle that's under probably the most stress as we're trying to bring our shoulder away from our body. There's the subscapularis muscle that's in the front, that's responsible for internal rotation. And then these two muscles, infraspinatus, teres minor, those are more towards the back. Those are responsible for external rotation. And of course, this is oversimplified. There is contribution of all of these muscles. Like for instance, if we're lifting something heavy or holding our arm away from our body, all of the muscles are going to be contracting at the same time to really support that ball and hold it squarely in the socket. And what we see is when some of these muscles are damaged or weakened because of tearing or even because of tendonitis, and they stop working, we start to see that the mechanics or how the shoulder moves is altered, and that ultimately affects the joint surface. It can cause arthritis, and then or just continued chronic inflammation. The other thing is that there's this bursa. Now, this is not the best drawing in the world, but if you imagine there's the ball of the ball and socket joint, then there's the rotator cuff, the supraspinatus portion of the rotator cuff. But above that is this bone called the acromion, which is really just this underside of this bone on the shoulder. There's a structure called the bursa between the muscle and the bone. Because the muscle is moving, the bone is stationary, so there's potential for a lot of friction there, and the bursa is built in there to decrease that friction. Of course, that can become inflamed as well, contributing to pain and weakness. Now, the superficial layer is pretty simple. I like to think of this as the layer that stabilizes the shoulder blade, but it's also the power muscle of the shoulder. The main power is the deltoid muscle, and that's this muscle here. And that's what gives us this shape of our shoulder. It's also quite powerful and quite durable. And so when we get shoulder injuries, it's almost never the deltoid that's actually injured. In fact, the deltoid is so powerful, and because it's vertically oriented, it has a lifting force. The deltoid is actually probably the reason why the rotator cuff wears so badly, because of that lifting force, trying to lift the ball up relative to the socket, and the rotator cuff has to accommodate for that. The pectoralis, the trapezius, these are muscles that stabilize the shoulder blade or are power muscles to move the shoulder with the rotator cuff. And the main thing to remember then is that the rotator cuff, really, the job of it is to hold that ball and socket joint. So it's seeing a lot of external forces from these other muscles, from the deltoid, from the pectoralis, but also from the weight of the arm, which gravity pulls. So if the arm's down at the side, gravity's pulling downward. With the arm up, well, now it's pulling with a different force, or if it's out to the side. It also, this is where when we are sleeping and we're laying on our backs, the force of gravity is pulling at a different angle. The rotator cuff has to accommodate for that, and that's actually why people struggle to sleep when they have a torn rotator cuff, because the forces of gravity are pulling backwards or forwards depending on the position that they're sleeping, and that's causing trouble because they may have weakness in the rotator cuff. So when we look at this drawing, you can see for the motion of abduction, which is just bringing your arm to the side, the main force is the deltoid. And you can see the deltoid has a very strong lifting force. And so what that does is that's going to lift the ball up. But the ball has to be held down, and it's the rotator cuff. It's muscle in the front, muscle in the back. That's subscapularis, infraspinatus, teres minor, kind of pulling downward so that it doesn't just lift up. And then supraspinatus is helping the rolling motion, because you can imagine as that ball, it's a combination of holding it down and rotating to get that ball to rotate around so the shoulder can move out. The main thing to remember is that this is all very complicated, and our body can just handle it spontaneously. But the problem comes when something goes wrong, a rotator cuff tear, weakness. It could be not even a tear itself, but from inflammation of the rotator cuff or partial tear that causes guarding and weakness from that. So then we start to talk about, well, all right, rotator cuff tear. Now this drawing here really shows that cuff tear as the supraspinatus. And really what happens is there's a watershed area here. And a watershed just means the blood supply to the tendon. If you imagine there's blood vessels coming in from the heart that's bringing in blood supply, those blood vessels come into this area here. And then as the blood supply extends further and further in, it trickles out. And then there's also blood supply to this, that's muscle, that's got a lot of blood supply. And as that blood supply goes here, they get to smaller and smaller vessels, and then it peters out. And so you've got an area here where it's got the end of the line, blood supply from one area, and the end of the line, blood supply from the other area. That little area is the weakest link. And so that's this portion here. Now, fortunate for us, that's a tendon, and tendons tend to be more repairable. If the blood supply was petered out through the muscle is much harder to repair. we would have a much bigger problem on our hands. Plus, usually it tears in a way that allows a repair with enough tendon remaining to repair that back down to the bone. Now, the main thing here to remember is this is a slow process because we're talking about just a little bit of wear and tear. And I think of it as like a timeline where it starts off as just a little bit of inflammation. Maybe it's overuse, maybe it's from a minor fall or some kind of an injury, and it just slowly gets worse over time. And then maybe there's a fall, maybe there's a car accident, a crash of some sort. That skips ahead on that timeline. And so the degenerative process kind of persists or continues. So over time, we start with a partial thickness tear, then we go to a full thickness, small tear, then it gets bigger, and then it's massive. At some point, we lose the ability to compensate for that. Most tears early on, they don't hurt at all. And so you can have, tears. People come in all the time with good sized tears. They don't even know something's wrong in there at all. It's only until it gets to be a certain size that it affects enough muscle where they're no longer able to compensate for it. Like I said, this is all very complicated. Our bodies generally take care of all this stuff by itself. And so a small tear, we can compensate for that because there's enough surrounding muscles to pick up the slack. But when that tear gets to be big enough, it causes real problems. So the idea here is, you start with conservative management. I definitely would suggest this. In fact, if everybody did this before they even came to see me, there'd be a lot less, uh, you know, visits. I go through this with a lot of people. The main thing here is we've got to manage inflammation, especially if it's from an injury. If you crash skiing or something like that, we want to give it a few weeks just to see if you're going to just bounce back. Because a lot of times inflammation by itself causes weakness. It doesn't necessarily mean that it's torn. So we talk about ways to decrease inflammation. That's resting, putting ice on it, anti-inflammatories, over-the-counter, pills. That's like ibuprofen, which is Advil or Motrin, or Aleve, which is naproxen, or even just Tylenol if you're not able to take anti-inflammatories. Now, the principles behind physical therapy is to learn to compensate for this. Now, typically it's that supraspinatus muscle that's, torn or injured, or there's inflammation. And so we want to strengthen the muscles selectively in the front and the back of the shoulder. And so this diagram here shows if you had a rubber band, you put that on a doorknob and you extend outward. That's going to build the muscles in the back in this drawing here. But then if you turn your body around and you're pulling internal rotation, you're going to build subscapularis. And so the muscles in the back and the muscles in the front can compensate for the supraspinatus, which is the muscle over the top. And we're making some assumptions, of course, that the supraspinatus is the injured one, but it's mostly, that's the culprit in most cases. And so there's phases. You start by just kind of taking it easy. That's what a pendulum is. You just let your arm hang down. Then there's these internal and external rotation strengthening, and then scapula retraction. So just kind of shrugging your shoulder blade to build those muscles. Then phase 3 is going to be more like getting back to normal. Activity-specific strengthening, progressive resistance, which is really just sort of like more normal strengthening exercises. And then if you're able to make it through that, your pain goes away. I think you're either the injury that you had was never really a tear, but perhaps just some inflammation, and you just needed some time and some strengthening to get through that. Or if it was a tear, you've learned to accommodate for that. So you've learned to compensate by strengthening the surrounding muscles that are uninjured to pick up the slack of the torn muscle. And if you're able to do this, I think it's great. I certainly would say, living with a small tear, isn't going to cause you any real long-term problems. Now, it's when people have trouble that the conservative management does not help, that's where the problem lies. So when I see a lot of people, we always talk about should we do an MRI? And of course, an MRI is like looking at the problem physically and how big, is it torn? How big is the tear? All that stuff. And I definitely think, when you get to a certain point and you've tried conservative treatments and they've failed to work, and you say, all right, enough is enough. I want you to, fix this thing. Well, of course, we need to get a good picture of it. We got to see what's going on, and an MRI is the way to do that. However, sometimes people come in and they say, hey, look, it's spring, it's summer, or it's fall, and I'm a winter sports guy. I don't want to do any surgery. I want to just get some relief. Or they say, hey, I want to do things in order from the least conservative or most conservative, least aggressive, step by step towards the most aggressive. So sometimes we'll be doing injections. And there's really kind of two different types of injections that we give. The first is a cortisone shot, and that's here. And that is um, strictly an anti-inflammatory. And the idea there is, hey, you've got this problem in your shoulder, and with or without an MRI, we say, look, it's the inflammation is really the source of the symptoms. So let's take the symptoms away with a cortisone shot. Now, if there's a structural problem in there, it's temporary. It's not going to be a permanent solution, but it may be temporary in the form of 6 months of relief or a year of relief, or maybe even longer, depending on the characteristics of what's going on exactly in the shoulder. And so for a lot of people, that's just a good place to start. Now, we also know that cortisone is not the safest thing for us. And so whenever I'm about to administer a cortisone injection, we talk a little bit about, hey, we're not going to give a bunch of these. We might only give one because there's risk with each subsequent injection that we give. And then, of course, depending on how bad the problem is and what the decision is, sure, there may be more cortisone injections in your future, but we got to kind of take it one thing at a time, one step at a time. Now, these other injections, that includes platelet-rich plasma and what we call BMAC, or bone marrow aspirate concentrate, is really just taking blood from your body in the form of, in a PRP injection, that's just taken it out of your veins. In a BMAC, it's actually drilling a hole in your bone and removing bone marrow, which is a little different but similar in process to blood. Then we take that liquid, we spin it through a centrifuge, and we concentrate it. Now, BMAC has an advantage that there's some stem cells in there. I will say the concentration is very small, and there's a few, stem cells in there. It's not a huge concentration of stem cells. In the United States, we can't really give high concentration stem cells. It's been outlawed because you need to get it from an embryonic source. But this is taking stem cells from our own body, and it's really, you still get the same advantages of the PRP, which is separating out high concentration healing growth factors, right? So we're taking growth factors, which would heal, kind of stimulate a healing response, and then we would be able to inject that, usually with ultrasound guidance, right at the rotator cuff. Now, if there's a giant hole in there, that doesn't fill the hole in, but if we're talking about a partial tear, we're talking about some thinning of the tendon, or somehow where, we just can't seem to get the inflammation to go away, and we're struggling with that, sometimes PRP does that. Now, technically, it's hard to predict. We know the results aren't 100%, so there's no guarantee. I can feel a lot more confident that we're going to get results from a steroid shot, of course, but they're different. From a PRP, we don't have the risk that we do with cortisone, with how many can we give. And if it's successful, frequently it's successful for a much longer time. But, it is still experimental, meaning insurance doesn't typically cover it. And, there will be a percentage of people that we do this on that it doesn't help. So that's always a conversation that we can have. Now, then as far as surgery goes, we're not going to spend a lot of time on this today. There's a lot of advances that have been made in the rotator cuff repairs. Obviously, arthroscopic repair, to me, that's the standard repair of the day. If it's a repairable tear, and so there's characteristics that we see on the MRI that tell whether it's a repairable tear without arthritis, usually just go in there and repair that. Sometimes, as we get older, because we're talking about a degenerative tear, sometimes there's thinning of the tendon, or sometimes when we look statistically at the healing rates, we say, boy, it looks fixable, but based on your age, based on the size of the tear, there's some risk for, lower healing rates. Let's augment that with either a patch or a PRP injection at the same time, which increases the healing potential there. Now, sometimes I see someone, usually they're a younger person, they've had a rotator cuff tear, usually an old injury that's been sort of unidentified, and they've been, adapting to it. where they'll have an irreparable tear, right? So there's some characteristics on the MRI with the atrophy of the muscle, but without arthritis, we can do a tendon transfer, and that's called the lower trapezius tendon transfer. It's relatively new. I like to look at that as it's an alternative to some of these other techniques, such as a superior capsular reconstruction or an in-space balloon, which are really static solutions, meaning, all right, we're putting a patch in there, but it's not moving. It's just sitting there. Or a balloon is actually like an artificial balloon filled with saline that lasts a few months, but it's just sitting there. It's not doing much. The lower trapezius transfer has advantages of being a dynamic solution. And so it's a muscle that we transfer. It actually is a muscle that stabilizes the shoulder blade. So it's active with shoulder movement. And we transfer it using a tendon graft to extend it, to, to replace the rotator cuff. It's synergistic, meaning that those muscles were contracting at the same time anyway. It still has its original effect on the shoulder blade. And so it is a very favorable transfer for that. It's also, because it's new, it's not commonly performed, but I do this fairly routinely now. Then, of course, if there's arthritis or if it's an irreparable tear and someone's not interested in the sort of lengthier recovery that may be with the lower trapezius transfer, then we talk about doing a reverse total shoulder replacement, and that's a shoulder replacement that is designed in a way that will allow the shoulder to move without the rotator cuff. So we are, kind of throwing a lot at you. We've got some great surgical options if needed. Injections, we've got a couple of great choices there depending on what you're looking for, but I definitely would start with conservative treatment first. So if you have any questions, you can certainly email me. I'm happy to see anybody that is requesting a consultation. I can certainly give you my honest opinion about what's going on in your shoulder and what might be the best option for you. So until my next video, hang in there. Let me know if you have any questions.